Dr. Tom Roselle live right now on 105.9 FM and AM 630 WMAL.
Welcome to Dr. Tom Roselle Live. This is Dr. Tom Roselle. I'm live in studio, 888-630-9625, 888-630-WMAL. Love to talk to you on any subject you have in mind. We have a topic, and we're going to try to put the fire out in a lot of different things that may be going on in your life. If you've had a problem and you've tried, you've applied, you've done everything you possibly can think of, and it's not worked, well, this is your opportunity to find out what can make a difference. And that's why you call 888-630-WMAL. We're broadcasting to you from 105.9 FM and AM 630 WMAL. My guest in studio, who will be your host this Wednesday evening at our in-house continuing education program, Dr. Harlan Browning. One of my brightest, best, and the guy that keeps me on my toes on a continual basis, because we're constantly going back and forth. And if somebody knows about something that's out there in the area of neuromuscular function, it's this guy. But we're going to be talking about a topic that many of you, unfortunately, are suffering from. Many of you will suffer from unless there's some changes, and that's hip and knee pain and the devastation, the debilitation, the potential replacement of those joint spaces, which, in my opinion, in the majority of cases are not necessary if they're prevented and they're addressed properly. Having said that, Dr. Harlan.
Good morning, Tom.
Welcome again, buddy.
It's always good to be here. And as I always say, when I'm sitting with you in studio, we need to do this more, but it just doesn't seem to happen. So we do need to do this more.
It does. And the thing with this is we're doing new things for our listeners as well. If you go on to RoselleRadio.com or you go to Roselle YouTube, you're going to start finding pictorial representations of the things that we're doing. There's going to be as time goes on, you and I will be discussing different topics. The other docs will be discussing different topics. Our whole idea is to educate as many people as we possibly can so they have choices in their life, so they don't have to be involved in drugs and surgery. So what we're going to talk about today is a topic that both of us see way too much of, as far as I'm concerned, in our office. But more importantly, the incidence of hip replacement is soaring, and many of the journals right now say by 2015 that there'll be in excess of 1 million surgeries done to do hip replacement, hip arthrosis, and knee replacement. That's awful.
It is awful. I think the problem is people don't identify they have an issue because maybe they don't have pain telling them there's a problem. So a lot of what I like to talk about with my patients is loss of function or changes in their ability to do everyday activities that might be a warning sign that something's coming down the pike, and it certainly could lead to a surgical situation.
That's the initial stages, and whether it's a shoulder, a knee, or a hip, when you start losing the capacity, you have a warning sign, a red flag, if you will, that goes up and says, pay attention.
Yeah, and we were talking about this on the ride up. One of the things that I ask my patients, and they look at me sometimes and they think it's odd, is I ask them, do you have a hard time putting your shoes on and tying them? And they're like, well, what do you mean? I'm like, can you cross your leg over the other one and actually tie it? And then they say to me, well, it actually is kind of hard. And to me, that's a sign that they're losing function in that hip. And if they don't do something about it, chances are that arterial surface or that cartilage surface is going to break down, and the blood supply is going to be compromised, and slowly that tissue is going to die.
It's amazing to me that people say, well, I've got to go in for a hip replacement. And I ask them, did your doctor tell you why it took place? No, they just said that I have osteoarthritis, that I have bone on bone. But did he tell you how that took place so you don't have other joints, your other hip, your other knees starting to break down? And they say, no, I don't. So my question to you is, for our listeners, besides loss of function, loss of function means I can't use something. I go upstairs and I can't get upstairs easily. I can't come downstairs easily. I can't turn without having some form of instability. But the big question is, how does this begin to take place?
Well,
why?
I think the initial fact is that a lot of people don't move around. They just don't exercise, and they don't activate their muscles. So if that's in place for many, many years, and let's say they have a desk job, so they're always in a seated position, then we're going to develop an imbalance of muscles. Usually the ones that are on the anterior side, that we call the flexors, become very strong, and the muscles on the opposite side, the extensors, become weak. Well, that scenario is not a good thing for our joints, because we need to have good balance from front to back. So if that's in place for long periods of time, and then we add some body weight on top of it, and we start to see the posture move forward, we get a little extra curvature in the spine, then all of a sudden that joint becomes ground down. And the end product is very often the person is looking at some sort of surgical procedure to undo, per se, that problem.
Well, with pain or loss of function or dysfunction, a patient, let's take an example. A patient's going to go upstairs. They're walking upstairs, and they notice that every time they go upstairs that their knee hurts. But when they go downstairs, they don't have any pain. That tells you something.
It certainly does.
What's happening?
Well, what it tells me is when they have pain going up the stairs, they have an equilibrium problem in their quadricep. The quadricep is going to propel them up the stairs along with their glutes, so that means that we're going to have certain parts of those muscles that are overactive and certain ones that are underactive. The end product is the kneecap doesn't track properly. It doesn't sit in between the two condyles of the bone, and it's going to rub more. And as it rubs down, it's going to wear down. And as the undersurface of that patella gets eaten away, we call it chondromalacia patella, then we start to hear noises, and we might hear clicks and pops and gravelly sounds. But that just means that we have permanency there. So that's an important thing to investigate when it first starts.
This Wednesday evening, Dr. Harlan Browning, my guest in studio, will be your host and presenter this Wednesday at the Roselle Center for Healing. He's going to be talking about hip and knee pain, how it comes about, but more importantly, what you can do about stemming the loss of functional capacity to this joint space and preventing the ultimate degeneration of osteoarthritis, leading to surgical interventions. We said that within the next couple of years, medicine is projecting that there's going to be about 1.3 million of you that are going to be going in for joint replacements of the hip and knee. Not necessary from our point of view. So if you'd like to attend Dr. Browning's presentation, 703-698-7117. That's 703-698-7117. Tell my staff that you'd like to attend this Wednesday, the 21st of March, presentation on hip and knee pain. Now, the problem is with these things is that it's just not an older person's problem. This is something that comes about earlier on. And I have a patient that just went down to her brother's house, and her brother just had hip replacement. He's a young man. He's in his 40s, and he was a professional athlete. And his joint space began to break down to the point where he had to have the joint done. So in this type of situation, we've got a professional athlete. This guy has a hip done. And why so early? What's happened in that sort of situation? Is it nerves that are pinched? Is it trauma to the hip? Is it dietary imbalance? What are we looking at?
Well, I would probably assume that in his case there's multiple traumas that added up over time, and as you traumatize a joint space, it's going to accelerate the speed in which it breaks down. If he's in his 40s, then we can safely say that the support system that was in place if he played collegiate football, baseball, or what have you, is probably not as good as it is now, meaning that he didn't have the resources as far as athletic trainers and the chiropractors to work with and all the constant rehab. So it was a play-through pain situation back in those days. So if you do that over and over again, the joint's going to take a beating, and eventually it's going to fail. And as it fails, the cartilage cap on top of the surface erodes, and then we get closer to bone, and then eventually we're bone on bone, and then we get a situation where we need to go in there and replace it.
My thing is always to look at where the electrical system starts and begins. And if we're talking about the knee, we're talking about the quadricep muscle, the big thigh muscle in the front. We're talking about the hamstring, the muscle behind us, and then other muscles as well. But they all have neurological innervation. So we know that if a nerve gets irritated, it can get compressed, pinched, it can get overstretched, it can get, and somehow the neurological flow is not normal. People don't understand that to have a neurological involvement, that you don't have to have pain, that the motor function of that nerve can be the primary irritation.
Right, and you certainly don't have to have the concomitants that we associate with nerve involvement, like, let's say, numbness or tingling or paresthesia, which just means a different feeling in that arm or leg. So you're right. What often happens is the body starts to try to compensate and protect us. So nerves will fire more to one muscle versus the other, and if that's happening, then that kind of accelerates the problem that we see. So in chiropractic, chiropractic, we know that by manipulating the joint at the level of where that nerve comes out, that it's almost like flipping a switch to it and restarting it. So it becomes a very important component in what I do, and certainly what you do in practice, is to look at the neurological innervation to that musculature.
This Wednesday evening, March 21st, Dr. Harlan Browning will be your host at the Roselle Center for Healing. He's going to be talking about hip and knee pain, not only why they come about, but how to fix them so you don't have to go through surgery to replace the joint to become a bionic person later on down the line. Love to have you as our guest, 703-698-7117. That's how you do that. Let's go to the phones. This is Dr. Tom Roselle. Welcome to the program. Hello?
Hello?
Hi.
Hi, can you hear me?
We can hear you.
Okay, I apologize, but it doesn't have anything to do with what you're speaking about.
That's fine, not a problem.
Oh, God bless you. About 2 weeks ago, I heard like a tail end of what you were talking about. I'm a cancer survivor. I've had 5 operations, breast cancer, and you mentioned, I'm extremely upset about mammograms. They always say that you can have many of them and they don't affect you. But I believe that you said a few weeks ago that there's 1,000 times more chance of getting cancer if you have mammogram.
No, there's an actual statistic that's out there, but it does increase your risk of breast cancer. If you have a minimum of 5 mammographies done in a row, it will increase your risk of breast cancer by up to a minimum of 40%. So, and then the more that you have after that, obviously, because think about it, radiation is one of the things that cause cancer. So you have the soft breast tissue being put in a vise and crushed and radiated. In my brain, that's a signal for doing some sort of permanent, ongoing degenerative damage to that soft breast tissue. There's many ways that are available to you to stem the tide, and thermographic imaging is one of them. And thermography centers is a group that we've been working with for a long time that we highly recommend and that we refer our patients to. You can go online at thermographycenters.com, and they will lead you to a lot of links. What thermography does, by the way, it doesn't identify or diagnose the mass, the actual tumor, but what it does show is the blood supply as it begins to develop before the tumor actually forms. So if you can see it ahead of time, you know that it's beginning to develop. There's a lot of things that you can do naturally, in my opinion, and there's a lot of physicians out there that know how to handle that type of problem. So I would suggest that, one, that you check out Thermography Centers online, give them a call, and add that to your annual physical. Mammographic imaging, my wife, many of our people in our office don't do mammography. It's their choice. They decide based on information, but they do thermographic imaging all the time. Now, having said that, if something comes up on a thermography and you see something that is suspicious, the medical physicians who read the thermographic imaging are going to say to you, you need to have further testing. At that point, you do mammography and you do ultrasound to identify the lesion. But anyway, that's what we know. That's my opinion. And again, go to thermographycenters.com. We're coming up to a break, and my guest in studio, Dr. Harlan Browning, we're talking about hip and knee pain and how it starts, what you can do about it, but more importantly, this Wednesday evening, the 21st of the month, Dr. Browning will be your presenter, your host at our office at the Roselle Center for Healing. You can give us a call at 703-698-7117. Welcome back. This is Dr. Tom Roselle. You're listening to Dr. Tom Roselle Live. We're in studio, 888-630-9625, 888-630-WMAL. Love to talk to you on any subject that you have in mind. Let's talk about hip and knee pain as well, because that's what Dr. Harlan Browning, my guest in studio, your host this Wednesday evening, the 21st, at the Roselle Center for Healing. That's what we're talking about today, and the ramifications thereof. But, knee pain can come from all kinds of things at any age, including young people, something called Ageless disease, which is a problem with the growth plates. Talking about gout, can talk about cartilage tears, but more importantly, pain that just kind of shows up and there ain't no reason for it, Dr. Browning. Doesn't seem to be anyway.
No, Dr. Tom, actually, obviously the presentation is on hip and knee pain, but we really could carry this over to any joint pain. It just so happens that I chose those two because we're coming into springtime. People are going to get out in the yard. They're going to do the yard work. They're going to try to initiate an exercise program, and we see these complaints at this time of year. But really we could carry this over to any joint problem because the mechanism is relatively the same. Either there's an injury that starts it, or there's an overuse that's in place.
Using a joint, any joint, that is not mechanically sound is a recipe for destruction.
Disaster.
It's like your car. If your car's not aligned and you're running the car without those balance in the wheels and the nose of that car being straight on, the car's going to break down. You're going to destroy your wheels. Pretty soon it's going to affect the entire mechanism of the car. The body is the same way.
Right. And when we talk about balance, I stress that it's a good balance between strength and flexibility. I see lots of guys at the gym who can put up a lot of weight, but they can't touch their toes. It's just as bad as the person that doesn't exercise at all because there's a restriction there, and that's going to carry over to the joints. So we want flexibility and strength. The interesting thing, and I'll put it on a personal level, that I've had a couple serious accidents over the last 11 years, and you're one of the guys that treat me in the office, and it was an injury that affected my neck and my back and not my hip and my knee and my legs. And I was with you.
And you were with me
when you hit your head. That's right.
That's right. We were in Vegas and coming off an escalator, and I propelled myself right into a marble pillar and hit my head, and it was not pretty. But the point is simply this. There's often days that when I start moving around, my hip and my knee are ridiculous. And I can't move, and it's because the muscles, the iliotibial band, the quadriceps, the hamstring aren't firing. But the accident I had was spinal related, not joint space to the knee and the hip. And when you treat me, you have to treat both ends of it.
We definitely do, because with you it's a matter of undoing what gravity and body weight and occupation for the last 35 years has done to you, which is basically compress you like an accordion. So most of what I do with Dr. Tom is manipulations and procedures to open and elongate him, literally make him taller, because his joint surfaces are just getting too close together, and now the bone is getting beat up.
And trust me, we're going to make sure that in the days that, when I'm fine, I'm not working, I'm not in the office, I've been to my Tai Chi Guan class and stretching out, I feel great. I move, I don't have any discomfort. But when those nerves in my spine get compressed and irritated, I come running in, and Dr. Browning throws me on the table, and he treats me, and I'm good to go. And it's stopping me until, he's got a big job to do, because I never intend to quit practicing.
Let me share something also.
And you can't quit the practice,
right?
Okay.
And with you, and this is the classic thing that's the disconnect between what we look at in conventional Western medicine and what we do in chiropractic rehabilitative type care. It's an ongoing process to maintain things. When the destruction's been put in place, I wish we could throw some magic dust on it and have it fix it. It just doesn't work that way, folks. So it's ongoing procedures that we do to ourselves. We exercise, we stretch, and we get our spine worked on, and we do those things to maintain it, because if we just let the course take its place, it's going to be inevitable that the procedure that we're going to have to go to is going to involve a surgeon and an anesthesiologist, and that's something I personally don't want to deal with.
This Wednesday evening, Dr. Harlan Browning will be your presenter, your host at the Roselle Center for Healing. He's going to be talking about hip and knee pain and what happens and how the body begins to break down. It's simply this. If you notice that you've lost function and you can't do what you used to do simply because of loss of strength in the lower extremity, and you don't feel like those joint spaces are moving, or in fact that you have pain, or the fact that the doctors told you you're headed for a replacement part pretty soon, this is an opportunity for you to find out what you can do to stem the tide and really reverse the process. I would encourage you, be our guest. Call my office, 703-698-7117. Welcome back. This is Dr. Tom Roselle. You're listening to Dr. Tom Roselle live. We're here at 888-630-9625. My guest in studio, Dr. Harlan Browning. We're talking about hip and knee pain, but how it comes about before it becomes a painful situation. Loss of function, loss of capacity, inability. Dr. Harlan Browning will be your host and your presenter this Wednesday, the 21st of March at the Roselle Center for Healing. Love to have you as our guest. 703-698-7117. That's 703-698-7117. Tell my staff you'd like to register for that presentation. If you'd like to re-listen to this broadcast of Dr. Tom Roselle Live, go to RoselleRadio.com. And we're starting to put things on YouTube, so you can go there as well. Love to have you follow us on Facebook. Dr. Harlan, let's talk a little bit about, and we're going to go to the phones, about how does somebody know and we get asked this all the time. Well, how do I know that I'm developing hip and knee problems? What are the signs? What are the symptoms? Is there anything people can do at home to kind of, use as a measuring stick?
Yeah, there definitely is, and I like to look at everything from the ground up and the roof down, meaning that we're going to look at the whole picture, the whole body. So some simple things that I tell people to do with themselves at home on an ongoing basis is this. If we want to look at the ground up, get a pair of your dress shoes and look at the heels on them. Are they wearing unevenly, or is there excessive wear on the outer versus the inner part? Is there excessive wear on the mid part of the shoe or up in the toe? If that's happening, then we know there's some dysfunction in the feet. And what that means is that there's going to be an upward cascade of that effect. If the foot overpronates or becomes too flat, it causes a rotation of the bone in the lower part of the leg called the tibia, ultimately causes a rotation in the upper part of the leg called the femur, and the end product is it puts more stress on the medial compartment of the knee and certainly puts more stress on the hip joint itself. And then if we want to look from the roof down, we look at the pelvis itself. So stand yourself up, put your hands on the top of your pelvic crest, that's the top of your hip bones, and look at yourself in the mirror. Does one hand look higher than the other? If it is, then you have some torsion or torque in your pelvis, and that's contributing to what's going on from that point downward. So we can do a lot of unnecessary pressure or damage to structures below just because our pelvis is a little bit rotated on the right versus the left, or vice versa.
I'll tell patients, so much of what they experience, neck pain, head pain, migraines, often starts from the feet, and they look at me like I'm weird. And I say, well, think about it this way. You have a house, and on the second floor of your house, the windows are cracking and the windowsill is shifting. Do you fix the window, or do you first go down to the basement and figure out why your house is dropping on that side to begin with? Because if you fix the window, the house is going to continue to drop down, and you're going to continue to have the problem, and perhaps even much more severely. So you have to look at every end of the body. If you just look at the area of involvement, you're in trouble.
Right.
Let's go to the phones. Carol from Silver Spring, how can we help you?
Hello?
This is Carol. BC, hi. Sorry, they pushed the wrong button. Anyway, BC, how can I help you, sir?
Hey, it was before the operation. I sounded like Carol.
There you go. We won't even go there.
We talked about 5 weeks ago, you may or may not recall, I had one of these wrist energy bands.
Yes, sir.
On my wrist. You wanted me to keep up with you. So I've kind of kept a mental journal since then. And remember, I told you I was the total skeptic, but I approached it in a very unbiased way and did notice a difference. Now, I don't recall if you said you'll notice a difference, you'll get to a peak or a zenith, and then it won't be much the same. Is that correct or incorrect?
Well, what happens with these wristbands, and depends on what type they are. If you look at the one that's on television where they put it on, they try to pull them over.
This was the black one with like a little insignia on top. I think you said you knew what it was.
Right. So here's what happens, is that it helps stabilize one portion of the neurological system, but it begins to break down other pieces of it, and does it over a period of time. But the way that we test it through muscle function testing, for example, we'll have a patient laying on their back, and we'll test a leg muscle, the iliotibial band, also known as the tensor fasciae lata. So the muscle's strong. Then what we'll do is, because the center portion of this is magnetic, if you will, we put it into the body's electrical system in one of the primary acupuncture circuits and retest the muscle. The muscle, if it's something that's stable, should maintain strength in any muscle that you test. But what we're finding repetitively over and over and over again is that in everybody we've tested, the muscles weaken as soon as the patient is exposed to it. Now, over time, your body adapts to weaknesses and stresses, but it does it at a cost to the physiology of the body. So that's all I'm saying to you, is that it will balance the system in one element, but because it's noxious, it's going to cause the neurological pathways to be challenged, if you will, and stressed in other areas.
Well, what I'm noticing is I'm going backwards now. I'm starting to feel the same aches and pains that I had prior to putting it on.
Exactly.
So you take it off?
Take it off and don't wear it at all.
And then try another brand? Or?
No, don't wear it at all. Okay, there's lots of other things that you can do. Send me a note on rosellecare.com, and I'll give you some things that you can do and some other things that would be appropriate, that if you're looking for that electrical balance, that neurological integrity, that you can do on your own, and some other products that will be useful. But get a hold of me, and I'll be more than happy to share that with you.
All right, thanks again for the information.
You're welcome. Carol, how can we help you?
In 2002, I had the Avon patellofemoral arthroplasty done to my right leg. Do you know what that is?
Yeah, we're following you. Go ahead.
Okay. A few years back, I started getting pains in the side, the outer side of my knee. And I just assumed, oh, well, this is one of those things. The problem was I got breast cancer in 2009, so I have tried to avoid x-rays. Getting back to my knee, a few days ago, well, it was actually Friday night, I went to sit down, and it was like somebody took and broke my leg in half. I got pains down the back, and it's over my instep now. I've got a restraining brace that I had on hand from my mother, and it's keeping it straight. But I don't understand what happened.
Carol, there's a lot of things that could be amiss here, and you have to take it from the point of a normal knee joint has to have muscle stability to keep it in a normal gait pattern. If any of those muscles weaken, then the joint begins to break down. Actually, joints will always shift to the side of weakness. However, now they do surgery, whether it's the type of surgery that you had or a hip surgery, the muscles are altered in their function. Unless they're reattached normally, unless you have a proper mechanism that has been put into place, it was right for you, that the leg length had not been altered. So you have many different things to consider here. My thought process off the top is that you have to find out whether or not the surgery has failed in any way, and whether the bony elements of the knee have broken down, because that's a significant amount of pain. Something has shifted, and I can't tell you straight up without seeing you, without examining you, what that might be. But the kind of pain that you said that you experienced is not normal.
Hey, Carol, this is Dr. Brown. Let me ask you a question. You said the pain is radiating now down into the instep of your foot. Is that correct?
Well, the pain has subsided, but the top of my instep it is like sore.
Okay.
And my pain started in the back of my knee.
In the back or the outside part of your knee?
Well, that's been for years, but then I've started getting this pain in the back of my knee, and when I would stand up, I would feel it, and when I'd go to sit down, I would feel it. And when this situation happened Friday night, the pain shot down my leg and over my instep.
Okay, so as Dr. Roselle said, the first thing that we have to consider is did the surgery fail somehow? Okay, so that's an important component. The second thing that I think about that when you describe that the pain is radiating down to the top of the foot is there's a nerve that curves around the little bone on the outside of your leg called the common peroneal nerve, and when that becomes compressed, which it often does, and because of improper shoes and things of that nature, then it's going to radiate pain down into the foot.
Or the fibula could have shifted as well, causing it.
So those need to be considered. If we're getting pain in the back part of the knee, there's a major stabilizer, another muscle called the popliteus, that certainly could be involved. And then there's always a consideration that there's scar tissue that's formed after the surgery, which is not uncommon at all.
The fact that you had pain even before the surgery that hasn't been ameliorated by the surgery, and now that you have other pain subsequent to the surgery, tells us that there is significant imbalance, but you have to look from the spine down to find out which muscles aren't firing, and then to correct that. But the first step that I would encourage you to do, Carol, is to find out if there's been any kind of surgical failure on the procedure. If that comes back negative, then there's a lot that we can do to help you.
Okay.
Carol, thank you for your phone call. I appreciate it.
Thank you.
This Wednesday evening, Dr. Harlan Browning will be your presenter, your host at the Roselle Center for Healing, the 21st of this month at 7:30 p.m. We'd love to have you as our guest. Give our office a call at 703-698-7117. Whether you have degenerative osteoarthritis or you have loss of function and you just don't move around the way you think you should, or you're younger and there's an Osgood-Schlatters problem, or you're developing gout, or there's a cartilage tear, this is a class that's going to give you a lot of answers and a lot of application. We'd love to have you, 703-698-7117. Dr. Browning, we're talking about surgery, so let's talk about what happens in many of these surgical cases when you have metal on metal.
Well, we touched upon this on the ride up because there's a lot of literature coming out that's showing that the prosthetic devices they're using, specifically metal on metal for hip replacement, is breaking down and failing. And what's happening is there's shards of metal that are coming off the surfaces. So
dangerous.
Dangerous, and it ultimately means another procedure needs to be done. So unfortunately, there's certain situations that I see, and I know you see, where a person lets something get so far that we can do palliative things, but ultimately their quality of their life becomes so compromised that they have to get surgery. And albeit we hope to get those people in our office way before this happens, but occasionally we see them. So the one thing that I tell my patients is make sure they do the research on the procedure that's going to be done and the type of equipment that's going to be put in, because not all things are created equal, and you need to be educated as far as what's going in your body and how it's being done.
There's some really excellent, if you have to get to that place where you have to have surgery, where the bone is destroyed and it looks like a rat got in there and ate it up, there's so much more that can be done. And as time progresses, I think 10 years from now, they're going to have a lot of genetic re-engineering of all the joint spaces. But still, the why is that, why it happened to begin with. And we look in our practice from the stresses that all of us go through, dietary stresses, too much weight on your body. Trust me, if you're overweight, you're destined to have a hip and knee problem and other joint space problems. You've got to get it off. If you're not functional, if you're not out there exercising and stretching and increasing your circulation, you are going to have problems. End of story. That's just the way it happens. But Dr. Browning is going to cover that this Wednesday evening. He is one of the best in that area of looking to the whys and how the neuromuscular system begins to work. What are you going to do this Wednesday evening?
Well, you know what? We're going to talk about how you properly work up a patient like this, meaning what are the questions that we want to ask someone to get the answers to help fix their problem. When did it start? What makes it better? What makes it worse? What do you do for a living? What kind of shoes do you wear? Do you exercise? Do you not exercise? And then we're going to look at the anatomy that's involved. You know me, Dr. Tom, I love talking about anatomy, and I love looking at the neurological system. So I really want folks to understand the way their body moves and how it's interconnected. And then we're going to go outside the box, as I always say, and as you say, and we're going to look at all the factors that culminate to cause our joints to fail. A small portion of the folks that I see have had one traumatic injury, and they definitely know that's why their knee went, or they definitely know why their hip went. Most folks just, it slowly comes on. So we're going to look at how you assess the body and how you can see the early signs to understand that something's going to probably happen down the road.
This is Dr. Tom Roselle. You're listening to Dr. Tom Roselle Live. We've been in studio at 888-630-WMAL this Wednesday evening at the Roselle Center for Healing. March 21st, Dr. Harlan Browning, my guest in studio, will be your host and presenter. Give us a call at 703-698-7117. That's 703-698-7117 for Dr. Browning's presentation on hip and knee pain. Let's go to the phones. Chris, how can we help you?
Hi. I'm not sure I'm having knee or hip problem, but it's in the general area. And I've had this maybe for 25 years. It happens mostly in the front part of my thigh, let's say from about the top of the pocket down to about 4 inches above my knee, and pretty much in the front of my thigh over to the outside rather than the inside. And it usually happens, I get a really sharp pain and really hard ache, and sometimes I'll notice that I can go down there, and that area, the whole area feels numb. I can even pinch myself real hard there and can't feel it.
Chris, is this in both legs or just one?
It generally happens when I'm standing still, like in the worst time was in November when I went to Disney World with my grandchildren and stood in these god-awful lines for what I had. The only thing that relieves it is either to sit down or to kneel down, even if I'm standing on concrete, on one knee.
Chris, let's address it a little bit because we don't have a lot of time, unfortunately. We're at the end of the program.
You know, Chris, if this is happening in the front part of your leg and there's also some associated numbness with it, or especially when you touch your leg, to me that sounds more like a nerve compression, probably in the upper lumbar spine. Is it happening in both legs or just one?
Generally, when it happens, it can happen in both. Most of the time, it's both. But when I kneel down, it doesn't matter. I don't have to kneel on both knees to relieve it, just one or the other, for about just 2 minutes, and it goes away. and it won't happen again for another hour.
Well, what's happening is when you're kneeling down, you're somehow unloading or decompressing that nerve. So, and if it's in both legs, then I start to think about stenosis. In other words, we're getting a narrowing of the exit where the nerve comes out. These kinds of problems are very, very treatable, but you need to get on top of it early, because as that degeneration continues, then we lose more and more room.
And pro-inflammatory, anything in dietary pattern, lifestyle, whatever, is going to progress it. It's going to make it much, much more difficult to treat as time goes on. So you got to put the fire out now, otherwise you've got a problem long term. Chris, I appreciate your call. I wish we could spend more time on it. Unfortunately, we're coming up to the tail end of this thing, and we can't do it.
Thank you.
We've been here at 888-630-WMAL. Dr. Browning, this Wednesday evening, a real about 20 seconds worth of what are we going to cover?
Well, we're going to look at the why behind all these aches and pains. We're going to look at strategies to fix it and stabilize it now. And we're going to look at long-term things that people can do to keep themselves happy and healthy. And you know what? A lot about what I'm going to talk about has to do with the whole body in general.
My pleasure, as always. Dr. Harlan Browning in studio, your host this Wednesday evening. Every Sunday, 12 noon, we're here for your listening pleasure and bringing you the best and most up-to-date information on integrative care. This is Dr. Tom Roselle. See you next week. Bye.